Hello everyone, welcome to today's lecture, Non-Carious Lesion. Topic learning outcomes: list the 5 non-carious lesions, explain the diagnosis and management of non-carious lesions. Introduction. Non-carious tooth tissue loss is defined as surface loss due to a disease process other than dental caries. Although decay is the usual cause of tooth destruction, requires operative procedures, it has been estimated that 25% of the tooth destruction does not originate from a carious process. So the non-carious lesions are attrition, abrasion, erosion and abfraction, and the fifth one is the combined one. So there are several causes for these conditions. That might be some habits such as bruxism, clenching of teeth, and some dietary factors, then lifestyle, that is maybe incorrect toothbrushing and use of abrasive dentifrices, and some factors are heterogenic causes, and most commonly these non-carious lesions are associated with aging process. So some of the causes are localized non-hereditary enamel hypoplasia, localized non-hereditary enamel hypocalcification, localized non-hereditary dentine hypoplasia, localized non-hereditary dentine hypocalcification, discoloration, malformations, amelogenesis imperfecta, dentinogenesis imperfecta, and trauma. So anything other than a carious cause that may act as a chance to occur the tooth loss, that is what we call as non-carious lesion. So some of the causes are this one. First one is attrition. So it is defined as the mechanical wear of the incisal or the occlusal surfaces as a result of functional or parafunctional movements of mandible. So basically it is a tooth to contact, and which occurs as a loss of tooth structure. So it is a physiologic process and it's a age dependent process. So mostly elderly people, you can see their occlusal surfaces are completely in the picture. You can see how it is looks like. So basically there will be loss of crown height and flattening of the occlusal surfaces. So these all are the common things which you can see in a attrition case. So basically it is more common towards the habits, something like bruxism. So first one is occlusal attrition. So occlusal wear is loss and flattening or faceting of the occluding elements, and it can also cause reverse cusp and loss of vertical dimension. So basically it is the loss of fattening and faceting of the reverse cusp of the occluding elements, and it leads to the loss of vertical dimension of the tooth. So if the if the loss of the tooth structure is severe and it is accomplished in a short time, and it may cause a lot of problems. So some of the causes are cheek biting, and it may cause decay also, because once the underlying dentine is exposed, and it may act as a cause for dental caries. And cheek biting, because there might be a vertical overlap between the working inclines, which will be lost as a result of attrition, and it might cause the problems to the surrounding cheek and lip. So these all are the certain problems, and of course if the vertical dimension is lost, and there will be problems for the TMJ. So next one is proximal attrition. So proximal surface loss result in decrease in dimension of the interproximal space. So as a result of that, there will be loss of tooth structure, and there will be widening of the proximal contact areas. So the surface area proximally increases in dimension, and which is susceptible to decay. Again, the dentinal tubules are exposed, and the mesiodistal dimension of the teeth is decreased, leading to drifting, and with the possibility of overall reduction in the dental arch. So this is the problems you occur with the proximal attrition. So coming to the treatment option. So treatment option decides by the pulpal exposure. So if there is a pulpal exposure, then you have two options. Either you have to go with root canal treatment or extraction. And the second one, if there is no pulpal exposure, then you have to look into the treatment strategies. So of course, if the attrition is deep and there is a pulpal exposure, you have to go for whether you can save the tooth or not. That is the decision you have to make. If you can save the tooth, you can go for the root canal treatment. If you are not able to save the tooth, extract it and replace the missing tooth. And no exposure, first thing you can think about the lost vertical dimension. You can use the occlusal splint. And secondly, if there is any habits, that habits has to be removed. So for that you can use the occlusal splint. Then you can resolve the TMJ symptoms to be resolved. So basically, if there is a clenching habit or a bruxism, first thing you can give the occlusal splint so that there won't be any more problem getting worse. Then the TMJ problem should be resolved. Then after that, occlusal equilibrium should be maintained. So how you can do it, that you have to make sure there is no high point. So if there is a high point, you have to make sure that it is removed with the help of an articulating paper. Then the high point should be corrected. So they should make sure that occlusion is proper. Then comes to the sensitivity. If the patient complains of dentinal hypersensitivity, then the treatment should be nerve desensitization, or you cover or plug the dentinal tubules. This should be the idea of how you treat the sensitivity. So you can use certain dentifrices, that is about potassium nitrate or any anti-inflammatory agents you can use, or sodium fluoride or calcium hydroxide, which can be used to plug the dentinal tubules. So there are a lot of abrasive agents available in market today, so you can go with that and try to reduce the sensitivity. That should be the first line of treatment. And the last one is the regain vertical dimension. It is a difficult one. You have to go through a process. You have to make sure how much of the vertical dimension is lost, and you can add according to the tooth surface slightly. So you have to add the increments in small, because if you add it in a bigger ones, it may cause difficulty to the TMJ. So you have to make sure the lost vertical dimension first, and according to that you have to add over the occlusal surface of the tooth. But because of the high occlusal stress, it is very difficult to control the lost tooth structure. So you have to make sure, if you have to go for something like complete oral rehabilitation, so you have to make sure the lost vertical dimension, and after that you have to add in small increments without causing much problem for the TMJ. Then you have to go for the, if it's needed, you can go for the crowns, or if you can maintain with the help of restorations, you can go with the restoration. So that's all about the treatment modalities for ATTRITION. So it all depends upon the pulpal exposure. If pulpal exposure is good, you can go for the root canal treatment or extraction. If it is not there, you have to make sure the occlusal equilibrium is maintained, and if there is any hypersensitivity, that should be controlled, and regaining of the vertical dimension. Second one is abrasion. It is the word derived from a Latin, that is abrade, defined as surface loss of tooth structure resulting from direct frictional forces between the teeth and the external object, or from the frictional forces between the contacting teeth in presence of an abrasive medium. So one type is masticatory abrasion, and of course everyone knows, as a result of tooth brushing. So that is about abrasion. It's quite common, most of the time you see in clinics patient complaints of sensitivity during brushing only. So it's maybe because of, most of the time if you talk about non-carious lesion, the common one is abrasion, and it can be related to the incorrect brushing technique. So toothbrush abrasion extent is dictated by certain factors. So one is direction of brushing strokes. So you should know which is the correct way to brush. Then size, percentage and type of abrasive, diameter and type of the brush bristles. That's why you always advise the patients to go for soft bristles. Then force use, how much force you are applying by doing the tooth brushing. Then type of the tooth tissue being abraded. So these all are the factors. Next, coming to the other causes: flossing, tobacco chewing, biting on hard objects, opening hairpins with teeth, biting fingernails, and PICA syndrome. So PICA syndrome is a medical disorder characterized by an appetite for substances largely non-nutritive, or an abnormal appetite for some things that may be considered foods, such as ingredients. So in order for these actions to be considered PICA, they must persist for more than 1 month at an age where eating such objects is considered as developmentally inappropriate. So that is all about PICA syndrome. So that is one of the cause for abrasion. Then some iatrogenic causes, that is occupational tooth abrasion. It can be associated with tailors, seamstresses, shoemakers, upholsterers, and instrument. Basically, whatever instrument they are using for their purpose, they have a habit of keeping it in between the teeth, and that causes the loss of tooth structure. Abrasion may be calcified as a notch or V-shaped effect. So that is which commonly seen in a clinical case, that is over the cervical part. You can see as a V-shaped defect, and C-shaped defect, undercut concave, and divergent box. These all are the few types you can see in abrasion. So coming to the treatment modalities. So when you talk about the treatment, first you have to diagnose what is the cause for the abrasion. So for that, you have to make sure you have to take a detailed history to be taken, considering various factors such as oral hygiene techniques like use of abrasive toothbrushing techniques and materials. Then the patient has some habits of using some smoking and tobacco chewing or any other professional habits. So these all things should be diagnosed first, and you have to correlate. So if you correlate with these causes, and you have to derive the diagnosis. So that is what we have to first. Diagnosis is important. You have to diagnose it correctly. So the habits and the reason for the cause. Then you have to make sure whether it is deep or shallow. So if the lesions are multiple and shallow and less than 0.5 mm into dentine, then no need to restore them. So basically it will be asymptomatic. And if there is an involvement of cementum enamel only, there also no need to restore. If the lesion is V-shaped and it is into the dentine, 0.5 mm into dentine, then restoration needs to be performed. In that case, most of the time patient complains of hypersensitivity, so the restoration is indicated in such cases. Then the edges of if the restoration is not required, then you have to make sure the edges of the defect should be smooth, and the demarcation pattern is relatively to the adjacent tooth surface. So these all are the things you have to be careful with when treating with the abrasion. So first find out the cause, then correlate the causes and derive the diagnosis. Once, if there is any habits or any incorrect method of brushing, you have to advise the patient how to. Basically, you have to educate the patient. Then decide the restoration or the defect is shallow or deep. Then according to that, you have to restore it. Sensitivity, again you have to either plug the dentinal tubules, or you can use the certain dentrifices and take care of it. Then restoration, if it is indicated, you can go for the restoration. Next is erosion, defined as a loss of tooth structure resulting from chemico-mechanical acts in absence of specific microorganisms. So there are two sources, endogenous and exogenous. So endogenous sources, so gingival clavicular fluid may be acidic, so it all depends upon the saliva. If the oral environment is acidic, there is a good chance for erosion. Then certain eating disorders such as bulimia nervosa and anorexia nervosa, it's a self-induced starvation, obsession with being thin, and self-destructive behavior. Basically both are eating disorders. In that case also you can see this condition. Then GERD, gastroesophageal reflux disease, an involuntary muscle relaxation of the upper esophageal sphincter, which allows reflux acid to move upward through the esophagus into the oral cavity. Symptoms are blanching, sour taste, and heartburn. So basically, the oral environment is going to be acidic, and it causes the loss of tooth structure. Exogenous sources: food substances with pH less than 5.5 can corrode teeth. So a highly acidic food, acidic beverages, carbonated drinks. Other substances such as chewable vitamin C tablets, aspirin powders, cocaine application, and alcohol abuse. These all are the other causes for erosion. And occupational tooth corrosion, that is professional wine tasters, industrial gases, and acids used for manufacture batteries, etc. So people work in this field of occupation can cause these same issues. Then how to grade the facial surface? So G0 means no erosion, G1 means loss of surface enamel, dentine is not involved, G2 involvement of dentine for less than 1/2 of the tooth surface, G3 involvement of dentine for more than 1/2 of the tooth surface. This is just a grading I have included in the slides. And grading of the oral and occlusal surfaces. Grade 0, no erosion. Grade 1, slight erosion, rounded cusp edges of the restoration rising above the level of adjacent tooth surface, grooves on occlusal aspect, loss of surface enamel, dentine is not involved. Grade 2, severe erosion and more pronounced signs than grade 1, and dentine is involved. So basically dentine is involved in grade 2, and grade 1 there is no involvement of dentine. Okay, treatment modalities. So basically when compared to attrition, abrasion, and erosion is easy to identify, because by looking the tooth only we can see the polished surface. It is easy to identify the case. So first you have to take a complete analysis of diet, occlusion, habits, environment factors, occupation, and medical history. So again correlate the findings. So if you have taken the complete data from the patient by asking the patient, and you have to gather all information, then correlates, you can easily make out the diagnosis. That is one thing you have to do with the all cases, all conditions, basically the 4 conditions. First you gather the data from the patient, then you correlate, and you have to find out what is the diagnosis. And once you find out the causes should be eliminated. So most of the time you have to understand what is the reason for erosion, the acidic condition, that has to be removed and made into a neutral one. So that is the treatment basically you have to do. Then treatment only if it is symptomatic. So again, if it is sensitive, most of the time if the erosion is there, it happens more over towards the palatal surfaces or the inside part of the upper tooth and lower tooth, but commonly it is occurring on the palatal surfaces. So you have to make sure, if the tooth is symptomatic, you have to go for the restoration or any other treatment, that is maybe in the form of root canal treatment followed by crowns, but it is very rare. But most of the time you can go for the restoration if it is indicated. If not, you have to evaluate the progress of the lesion with the help of study models and photographs over a period of time. So you can recall the patient over a period of 6 months or according to the condition, and you have to monitor the patient's status. That is what you can do for the erosion. So first, complete data should be gathered by talking to the patient and correlate the findings and derive the diagnosis. After that, the causative factor should be eliminated. Then treatment is required if the tooth is symptomatic. So most of the time patient won't be symptomatic, and you can see the tooth surface is really polished and smooth, then there won't be much issues. If the lesion, if the erosion is not happening for a long time, you can identify from the tooth itself because of the stains or anything present or colors discoloration present on the tooth surface. Most of the time it should be clean, so that means the erosion is happening. So you have to evaluate the progress and treat accordingly. So in the picture you can see, because of the improper occlusion, there might be a small break in the enamel, that is a hydroxy uptake. Then later this force keep on coming over that area and it develops into a small V-shaped notch. It is something similar to abrasion, but the reason for abrasion is more commonly relating to the improper brushing, but whereas in abfraction it is more related to a biomechanical loading forces. That means improper, more commonly towards improper occlusion. So some of the types of abrasion are enamel hairline cracks. Then common one, that is the McCoy notches. You can see in the picture, it looks, the pulp is exposed here. You can see it, the notch is so deep so that it almost reaches to the other side. Then circumferentials all around the tooth, saucer shaped and semiluna shaped, multiple subgingival below the gums only. You can see lingual surface, crown margin, below the crown margins also, and below the restoration margins. So that are the few types of abfractions. Then the combined lesions, it is combined with the attrition and abfraction. So attrition, you know, because of the improper occlusion only it is happening, and adding to that it also causes the abfraction. So the joint action of stress and friction. Abrasion and abfraction, so friction from the external material onto the areas of stress and concentration. So it is very difficult to identify the difference between the abrasion and abfraction. So you have to take a detailed history, then only you can identify what is the cause. And once there is a weak element happens over towards the cervical margin of the tooth, and it can deepen the issue with the cause of abfraction. Erosion and abfraction, again action of chemical corrodant on areas of the stress concentration. So acidic condition which removes the loss of tooth structure much faster, and adding on to that the stress concentration comes towards the cervical margin. Coming to the treatment, so first one is preventive intervention. So to identify the preventive interventions, you have to first identify what are the causative factors. So according to that you have to do the treatment. So first you have to get the detailed history, and from that you have to identify the causative factors, then do the preventive measures, then monitoring progression of the lesion with the help of photos and cast, and if it's required you need to do any occlusal adjustments, and occlusal splints can be given. Then hypersensitivity, that has to be managed with the help of desensitizing paste. Then restoration is required. If the tooth is symptomatic, definitely you have to go for the restoration. If the depth of the loss of the tooth structure is less, it's not advised for the restoration. Then you can monitor over the period of time. Then root coverage surgical procedures in combination with restorations are also advised if it is required. So that is about the treatment for abfraction. Okay, coming to diagnosis as management. So first one is history of the patient, and second is examination. So take the complete history of the patient, that includes diet, habits, medical history, etc. Examination of the tooth loss. So identify the tooth loss, how is it, and the surface is polished or not, or if there is any wedge shaped defect like that, you have to make sure that clinically you identify the tooth loss, and correlate with the history, whatever habits can relate to that. Once you relate the history of the patient and the clinical examination, you can derive the diagnosis. So once the diagnosis is derived, then comes to the treatment. So the treatment, preventive interception is always first. So whatever the causes, that has to be eliminated first. So educate the patient about that, and make him understand what is the problem, and try to discontinue that, whichever it is, if it is a habit or anything else. Then come to the restorative management. Restorative management, again it depends upon the scenario, whether the pulp exposure is not there or not. If pulp exposure is there, then we have two options, either you are going for root canal treatment or extraction. So if the tooth can be saved, advise RCT and followed by crown, and if the tooth is not able to save, then you have to go for the surgical removal. When it comes to the restorative treatment, you have to look into the dentine involvement. So if the cavity or the loss is involving dentine, definitely you have to go for the restorative management. So the advisable is geomos, that is the resin modified glass ionomous cements or composites, and glass ionomous cements have a advantage over composites because of the fluoride release. Then if the restorative management is not required, you can go for the normal fluoride varnishes. Then if there is a case of hypersensitivity, it has to be managed with the help of desensitizing paste, and if a minor occlusal changes, that also has to be managed. So that is all about the diagnosis and management.